Great to see so many of you. So yeah, welcome everybody to the Health Literacy Community of Practice today. My name's Emma Davidson. I'm the Strategic Manager for the North East and North Cumbria ICB's Health Literacy team. So lovely to see so many of you on the call today. I'll just start by running through some housekeeping for everybody. So microphones and cameras are off by default. We will allow those when it comes to the discussion panel. If you do have any questions, if you could use the question and answer facility, and if you can't see that, if you email Kia Thomas and she'll look into that for you. We will try our best to answer questions throughout the session, or like I say, during the discussion panel. If there's any we don't get to, we'll circulate questions and answers after the session with the rest of the materials. Obviously, if you needed to take a break at any time, please feel free to do so. All the presentations and support information will be circulated after the event. And as you've just heard, the event is being recorded, and that will also be shared and made available on our NHS Futures page for this community of practice. If you no longer wish to attend these meetings or receive updates, you can email Yo-Yo Kwan, and her email address is just on the screen there as well. Thank you. And just to briefly go through the agenda for the session, so we've got quite a packed agenda. So we've got an update first from Ranjit from NHS England. She's our Healthcare Inequalities Senior Professional Advisor from the National Healthcare Inequalities Programme, and she's here to give her an update on the National Health Literacy work. We've then got Claire Gilliland from the Royal United Hospitals Bath NHS Foundation Trust, who's going to talk about Care to Translate. And then we move on to Hashim Shah, who's from Birmingham Women's and Children's NHS Foundation Trust, who's going to talk about their work with written medicine. Then we'll move on to a discussion panel. So it'll be your opportunity to ask questions of all the presenters at the start of the session. Like I say, so welcome to put your questions in the question and answer function, and we'll try and read those out. Or like I say, we'll enable microphones and cameras for the discussion session. So if you do have a question when we got to that point that you'd like to ask, if you raise your hand, and again we'll try and get through as many of you as possible. And then the session today ends with the interactive session on what is your jargon, and that's going to be presented by Lorna Dawson, who's Health Literacy Special in the North East and North Cumbria's ICB Health Literacy team. So the first presentation is from Ranjit from NHS England. I'm just checking through to make sure Ranjit's been able to join.
Yeah. Can you hear me, Emma?
Hello, Ranjit. Thanks very much.
Hi.
Yes. Would you? Hi. Welcome. Would you like to take control of the slides and move through them yourself, or would you like Kia to do that for you?
Yo-Yo, is it Yo-Yo looking after them?
It's Kia today.
Kia, yeah, Kia's fine. That's fine.
Brilliant. All right, great.
Okay. I'm going to hand it's myself. Yeah, I'll do a double act between myself and Sophie, and so yeah.
Brilliant. Right. Thank you. Thanks, Ranjit.
So hi everybody. Thank you, Emma. Shall I start? Okay. Brilliant.
Yes, thank you.
So good afternoon, everybody. I'm Ranjit Singh. I'm just going to, I look after the Health Inequalities Improvement Programme around health literacy, and we were really keen to make sure that health literacy and the work around health literacy continues to be a key area, because one of the things that we know when it comes to equitable access, we know that people who live in our most core 20 most deprived areas, there are massive issues around what we do wrong as an NHS in terms of making sure that our information is addressed with a health literacy lens. And I know from the audience on the community of practice, I'm preaching to the converted that we've got to make sure that health literacy is addressed in its all shapes or form, in all its different approaches. And so what I'm going to do today is just give you an update of where our programme is sitting, because conscious lots of changes and lots of things that are going on outside of with the merger with Department of Health. So we thought it'd be good to give you an update as to where our program is. And then also I'll hand over to Sophie to just give you an idea of what the health literacy program is about and what we're driving forward for 25-26 and what some of our delivery is. Next slide, please. So what we've got here is just some of the key drivers, the national drivers, and what are the expectations. So as NHS England evolves and starts doing more joint working with Department of Health, Department of Health and Social Care, we've got a number of things that we still have to look after. So there's the Government Health Mission around economic growth, and it's making sure that health inequalities agenda is part of that reform. Where we've started the implementation of the 10-year health plan, and this is about how do we build on the 3 steers that were outlined in the Darcy review. And then our previous director, Dr. Bola Awolabi, very much talked about, ran actually a working group that looked at I Feel Included Regardless of Who I Am, with Jacob Lant from the CEO of National Voices. And they did some really good work that made a difference in terms of feeding into the whole engagement progress. And then we also, for our team, we lead on the work around infected blood inquiry. So I'll tell you a bit more about that. So these are some of the levers. We know that we're going through change in legislation and the reform bill is underway. We're working with, obviously we've got key metrics in the NHS oversight framework. This is around health inequalities metrics. So if we can't measure it, it is not going to happen. So we've got to make sure that we continue to get smarter about our metrics. And also we're in the middle of the medium term plans that ICBs are drafting, and the narrative plans that are being put forward for February. And so we're looking at those with the regions to make sure that they have a health inequalities lens. Next slide, please. On those plans, just to let you know that we're making sure that like last year we launched the community languages framework. We want to make sure that there's action around health literacy, that there is funding that we give to each of the ICBs, and we want to make sure the integrated care boards, and we want to make sure that that is on track. That when we talk about meeting our vision around equitable access, excellent experiences, and optimal outcomes, we're making sure that that's for everybody, not for those just worried well. So what this slide does is just really outline where we are as in December 2025. So our purpose and vision is very much the same. If you've worked with us over the years, in terms of our program, we've had 5. We've had the core 20 for adults, the core 20 for children and young people. They continue to be our framework for delivery, and we're continuing to drive a lot of the work with the core 20+5 lens. The only difference with what we've got here is the green slide, the green bit about the health inequalities strategic priorities. So previously we had 5 strategic priorities, and they were like inclusive recovery, digital access, one around metrics, leadership, accountability. So what we've done this time is we've done three priorities. These are equitable shift to neighbourhood health, the equitable shift to prevention, and equitable shift to digital. So they align with the 3 steers that are outlined in the 10-year plan. And then the three enablers that we have is the shifting financial resources, making sure that number 5 is transforming accountability and performance. And in that we have leadership, as part of that. So I lead on that around making sure that our leaders continue to lead and drive healthcare inequalities. And we have metrics and performance levers to drive to measure the impact. And then our sixth one is around going back to what I mentioned earlier, the independent blood inquiry. There's a lot of recommendations in that inquiry around sickle cell and thalassemia. So we're continuing our work program on that. The Shift Financial Resources work stream, which I also lead on, is going to be really good. It's looking at the ACRA review. It's resource allocations. So all the funding that goes forward around health inequalities, we want to make sure that that's done. And I suppose my question to the audience here is to make sure that the funding continues for health inequalities and it doesn't just fall off a cliff edge as these changes come in. So our team's delivery model has always been healthcare inequalities. What is it that the NHS can continue to do and drive? And we will continue with the healthcare focus. We do have a Department of Health team and on health inequality, who lead on health inequalities also, but they do the wider determinants of health, and whilst we do healthcare inequalities, and there are some overlaps. Next slide, please. So this just tells you that our four distinct roles are very much about meeting our vision, making sure that we push on NHS as an anchor institution, make sure that we as an employer, we have the right workforce. We also have preventative mechanisms in that's priority too, and then we make sure that we're working collaboratively with ICBs. And I think the key driver in all of this is delivering to the government's health mission for addressing and tackling health inequalities. So it's making sure that the healthy life expectancy gap, we're working to address that through everything that we do. And what Core 20 continues to offer us is an opportunity really to drill down into those areas where we know that illness is something that, and tackling health inequalities has to be a priority. Next slide, please. So this just gives you an overview of what I've mentioned in terms of core priorities. The three shifts are above, and then the enablers. I think that I've given you a little bit of a description on each one. So what you'll see over the next, and I think Sofian's going to pick up probably the next slide, but what you'll find in the next couple of months will be our team sharing you the new narrative. So we're sharing this with you now. That's where we'll be angling our priorities going forward. So I hope that helps. Next slide, and I think we'll pass over to Sofian. Okay, Sofian, are you?
Yeah, cheers.
Brilliant.
Yeah, thank you, Ranjit. Afternoon all, and very nice to be here. So I'm just going to quickly run through some of the key activity we've got as a national team. So the aim of the National Health Literacy Programme is to accelerate delivery of health literacy organisations across the NHS and wider healthcare agencies. And some of the sort of pieces of work that we're currently leading on, or will be sort of leading on until sort of the end of March 26. So there is an update of the readability tool. So for all of those that use the readability tool, the NHS readability tool, there will be an update. We're working with the University of Surrey with that and the Knowledge and Library Services. So essentially, a couple of bits that will happen is sort of, bug fixes, just like an app updates, etc. Checking of the reading age calculations, just to make sure that what we're putting into the tool sort of is correct in what it pulls out. And also expansion of the tool dictionary to include new sector-specific terminology, and a few other bits that will be updated on the readability tool as well. We're also working with Patient Information Forum, and they are They are a membership organisation for anyone producing health information and support. And what they promote is access to trusted, evidence-based health information for patients, carers, the public, and healthcare professionals. They have a PIF tick, literally a green tick. I'll hopefully put it in the chat for those that don't know of Patient Information Forum. And essentially, they're an independent trust mark for health information. So they have a lot of sort of health posters, trying to navigate, sort of wrong or misled information in social media, TikTok, Instagram, that kind of thing. And they kind of provide that accredited mark. For us specifically, they've already got some, well, I say some, they've got a lot of healthcare information posters. And what we're looking to do is work with them. So some of the sort of collections, we can translate them into different languages. So if you can see the middle sort of bullet point, create translation of 4 popular information posters in 5 different languages, trying to be as inclusive as we can. And we've had a bit of a criteria for that. We're also going to be creating a short YouTube video on sources of misinformation, and again, hopefully we can create products that are used across the system, and that's the aim of it. So they will be on our Futures website, and we'll try to distribute them through this network and etc. We're working with the North Cumbria ICB, so Emma and Yo-Yo, etc. And 2 things: working with leading this national health literacy community practice, which is fantastic. And also we're looking to sort of have a national NHS Futures platform where we've got all the regions kind of with lots of updated information and sort of working together to shape their sort of respective pages. And we know there's lots of great work happening across the system. We just probably need to get it down onto Futures. So that's another piece of work. And then we're also working with NHS Knowledge and Library Services and Health Literacy UK, who are an independent KIC. Again, colleagues may have heard of some of the colleagues that work with them. So it's like Dr. Tanya Cork, Mike Oliver, Jonathan Berry. They're the key stakeholders. And what we're looking to do with them is update the health literacy e-learning resource. And B, we're looking to have a sort of series of best practice webinars, and also the middle bullet point there again, a report to highlight how taking account of best practice will make a significant contribution to the delivery of the 10-year health plan. And so Rajit touched on that a little bit more, but for those that have read it, and not just the executive summary, health literacy is highlighted quite a few times. So it's on the top of the agenda for government. And hopefully we can sort of, alongside all the stakeholders in this group, I can see 143 people, hopefully we can sort of take that to the next level. And that's us. Thank you very much for listening. Happy to take any questions in the chat, etc. Thank you, Emma.
Thanks, Sofian and Ranjit. That was brilliant. Thank you. Are you both able to stay till the discussion panel as well? Brilliant. Yeah. So yeah, that's great. So if anyone does have any questions, you can either pop them in the question and answer function, or we'll come to it when we come to the discussion panel as well, and we'll take questions there. So I'd like to hand over now to Claire Gilliland for her presentation on Care to Translate. So thank you, Claire.
Pleasure. Can I just check something with you, because I was told I had sort of 5 minutes, and I thought that the group would already know something about Care to Translate. Do people know nothing about it? Feels like I'm coming in cold. I might just add a bit if you know nothing.
It would be helpful to for you to let us know more about Care to Translate. Thank you.
Right. Sorry, I think I've just misunderstood the brief slightly. So if I have, I apologise. So I'm going to just very quickly give you an overview of it, because what I was asked to do was tell you about our challenges. So what I'm going to do is just show you what it is, so you know what I'm talking about. So Care to Translate is a translation app that you can have on any device. You can have it on a phone, an iPad, any kind of tablet, or indeed on a web link, which is what you're looking at here. But it looks exactly the same on here as it does on your phone. There are 2 sides to it. The patient side, which I'll just mention to you that the patient app is free to patients, and it will always be. So anybody you know who's living in this country who doesn't have great English, they should have this app on their phone, so that if they find themselves in a medical situation, they can actually make themselves understood. And I can switch to the patient side anytime I want by just switching it across. So if they don't have the app and I want them to tell me stuff, I can switch across and it'll put it into the language that I've got it set to at the top, and I can just switch back again. It's a very simple app. It does have a lot of content that's been built by Care to Translate, but these that you see here are our templates that we have built. So each one is a playlist of the sorts of things that you might want to ask in that situation. So if I click on pain and labour, these are all the things that I've pulled from the Care to Translate library into this section so that we could talk to the woman if we needed to, just get some basic information from her. You literally just click play and it will play to the patient what it says there, but it will also show it to her, so in her language. And there's some extra bits on here. So we have on here our cost codes for our various different locations. So if staff need to get through to an interpreter, they can do that. You can also just search. So if I just search blood, then I'll get all the things that mention blood. And I can ask for one of those if I think it might not be on my playlist. And there's also a live translate function, but as it immediately says to me here, it's an AI feature. It's essentially the same as Google Translate, but without the data stripping that Google will do to you. So the playlists are properly ratified by native medical speakers in those tongues, and there are, I think at this point, 46 languages, something like that. So that's essentially the app, which I'm really sorry for that being so quick, because I didn't know I was going to have to tell you that. Up here I also have the portal, which is my end of things, so that I can look at the app and see what's been going on, what my most used languages have been, number of sessions, those kind of things. So that's where I have all of that. Right, back to my presentation. Would somebody mind just sharing my slide?
Bear with me 1 second.
No problem.
Is that auto update?
I may have it here somewhere. In fact, I know I have it here somewhere. Might just. I'm just going to let you drive.
Loading now.
Okay, great. Thank you so much.
Sorry.
I mean, it goes.
There we go.
There we go. So, yeah, what I was asked to explain was kind of what challenge it met and then what our challenges were with it. So on the left-hand side of the screen, what I wanted to explain to you is that Care to Translate is not designed to replace translation. But what I had realised is that if you don't speak English, if you speak English, let's take it from that point of view. Do we just speak to you about the major things that are happening? Do I only speak to you when I need consent for a procedure? Or do I chat to you constantly through the day or through the time that I'm with you, the appointment that I'm with you? We, at this point, were just looking at maternity, and there were 3 areas that I had really thought about, that I thought we're not covering these areas with our traditional interpretation services. So the first was the unexpected. So the woman that just walks in the door, she doesn't have an appointment booked. You know, we run community services and acute services over 5 different sites. So just that woman who has just arrived because she knows there's a maternity unit in this building and she's frightened about something, I don't want to just sit her in the corner and wait for the interpreter to be on the phone before I can ask her why she's here and if she's okay. So that was my first gap, as it were, of, you know, people just walking in the door. The second one I called interludes. Those are the bits. So say you're looking after a woman for 12 hours with in labour. If you're going to get a cesarean, you know, if you're going to have a cesarean, if you're going to have an epidural, you're going to get an interpreter on the phone to talk to them about the risks and benefits of that course of action. But in between, I need to ask her, are you okay? May I touch you? Are you thirsty? Are you warm enough? Can I get you something? Can I put my hands on your bump? These sorts of questions. Those things that if you were English speaking, I would talk to you all day. And I don't want to just leave you sat without any communication between myself and you all day if you don't speak English. And the third one was the snippets. The little tiny things. The one I always use as the example is on the postnatal ward. And that's because when I was clinical, I must have mined this several times a day often. Can you pee in this container for me? You know, what's happening with your bleeding? Are you hungry? Do you need a drink? Is your partner coming to see you soon? Those kind of quick, short things. They're such short interactions, little snippets that I don't have time clinically to sit on the phone and wait for the interpreter in that language. And so what I wanted and what I found in Care to Translate was an app which would fill those three sorts of situations, those intermediary bits. I never intended for it to replace interpreting services, and it hasn't done. But it has been useful when I've not been able to get an interpreter quickly, or if we've perhaps, I would say, not had to call interpreting services as frequently because we've been able to have those things. Now, in terms of successful engagement, we did a bring your own device trial. Care to Translate were very good. They offered us a free trial. And I thought, great, we'll do it on bring your own device. Everybody's got a computer in their pocket. They'll all love it. What I discovered very quickly is that not everybody, but a lot of people did not want to use their own device. They have just a basic, in principle objection to using their own phone at work.
Yeah, there was a couple of people.
Which I was really surprised about as a digital lead, because I've got no problem with using my device, but also as a manager of maternity services, it's quite frequent that we have to tell people to go and put their phone in their locker and not have it in their pocket. And therefore, we really didn't think that they would have such an objection, but they really did. We're aware that the direction of travel is that people are going to have to use their phones. There's no way that the NHS is not going to take advantage of the fact that they've got free computers on every clinician. But because they didn't want to use their own device, I had a real lack of data to be able to prove to anybody who might pay for these things that I could use Care to Translate and that it was going to be useful moving forward. So I decided to go to Innovation Panel. Innovation Panel in our trust, you can apply for funds under 20 grand. And so I put together an application, which I have shared with the organisers of this group, and I'm happy for it to be shared with anybody who would like to see what I did. But I didn't want to bring it here because it's 6-7 pages long, just explaining what my intention was. And I went to present. As a result of that application, I was successful, and I was asked to present to Innovation Panel, which was by far and away probably the worst thing I've ever done in my career. It was absolutely terrifying. It was about 15 people who just kept asking questions. But in the end, we did get money for 1 year of licenses and 8 iPads. So we just thought we would have an iPad in each area that was labelled Care to Translate. It was dedicated purely for that purpose, and it just stayed there. We got all of those, including the hard pack, tough pack covers to keep them safe. And we ran the trial for a year, and by that point it wasn't really a trial, was it? It was the implementation, but we ran it for a year, and after that year I was able to show that we did have the data to support it for moving on into a second year. And so then I wrote the business case to get a second year, which is where we are now, just approaching the end of our second year. And what I would say is that Bath, you may not know, or you may know, Bath is quite a white middle class area. If I literally go over to Bristol, 10 miles in the other direction, I'm going to find a lot more multiculturalism and a lot more languages spoken. But so that is reflected in our numbers. But what our numbers show us is that sometimes we have, a woman who is an inpatient on our ward for maybe some weeks. She might even be there antenatally for 5 or 6 weeks. And so our use does go up and down. You very much see that. I think you probably saw that on the portal thing that I showed you earlier on, it showed you our use over a year, and it was kind of lowish, and then there was a big spike in July, which is when I think we had a mother on the ward for quite a period of time. So it does go up and down, but we have an average use of probably about 50 or 60 uses a month. And they are all short, which I would expect. I can see on the portal that they're all kind of generally less than 6 minutes, which again, I would say is a good thing, because it means people are getting interpreters for the more complex conversations. That's it really. That was just to give you a little overview of where we came from.
Brilliant. Thanks very much, Claire. That was really helpful.
Pleasure.
And great to hear about how it's been done within your trust. And yeah, we'll certainly share the innovation panel application form with all the materials from the community of practice. But thank you. That was really good to hear about. Claire, are you okay to stay around till the discussion panel?
Absolutely.
Brilliant, thank you. So again, if anyone has any questions for Claire, if you can add them to the question and answer, or again, there'll be opportunity to pop your hand up when we come to the discussion panel. But thank you again, Claire. And now I'd like to move on to Hashim Shah, who's going to talk to you about written medicine. Thank you, Hashim.
Hello, everyone. My name is Hash. I am excited here to speak to you about a simple but powerful tool that can make a significant impact on patient care and experience. I'm here to share a simple idea. I believe that medication labels, can change lives. But before we do that, I just want to give you a quick challenge. Don't worry, it's not a test per se, at least not yet. So in a moment, I'm going to greet you in 20 obscure languages, as you can see on the cards on your screen. I normally do this in person, so I have to improvise a little bit virtually, but the point of this is this small interaction between us reflects the kind of patient experience that we're here to talk about. But to up the ante, I don't have the phonetic spelling to languages, as you can see here. So we're going to do this we're going to start with a little bit of trust and vulnerability to build some relationships, and hopefully we can create some communication along the way. So without further ado, good afternoon, everyone. Or should I say, Iskawaran, Bawani, Marhaba, Salam, Kemcho, Satyakal, Namaskar, Ni Hao, Neho, Starimashi, Salam, Slow, Vanakam, Shinchao, Kumusta, Chech, Salut, Marhaba, Bujambo, Bonjour, and Kia ora. Now, I need to be honest here. I definitely butchered one of those. The Kurdish Staribashi, I'm looking at that one. However, I just want to make the point. Who here remembers the first word that I said? And that exactly is my point, to be honest with you. If we as healthcare professionals can't recall a simple gathering from 60 seconds ago, then how on earth can we expect patients to remember critical, often life-saving medication instructions spoken quickly in a stressful environment in a language that they don't understand? Let's talk about what happens when we stop relying on memory and start using systems that speak our patients' languages, literally. So I'd like to start by highlighting the scale of the problem we face when dealing with patients who have limited English proficiency. 10% of the UK doesn't speak English as a second language. In Birmingham, where I'm based, 5% don't speak English at all. So what happens when these patients don't receive medications? These patients are the most at risk. In our healthcare system, millions of patients currently run the risk of miscommunication, especially when it comes to something as crucial as medication labels. Patients for whom one misunderstood label can mean hospitalization. We know that clear communication is essential to healthcare. It's drummed through us throughout our entire careers and while we're students. So when patients don't fully understand how to take their medications, it can lead to dangerous errors that can lead to hospitalizations and even death. Language barriers in particular have been linked to higher hospital readmissions, lower medication adherence, and worse overall health outcomes. I'm a pharmacist. In that case, pharmacists are often referred to as the gatekeepers of the NHS, often being on the front line to the public minor ailments. But doesn't that mean all of us have a role in safeguarding it too? When patients don't understand their medication instructions, the consequences can be severe. Let me share an example from a real case that we have faced involving methotrexate. The patient was a 17-year-old girl, was supposed to be taking 12.5 milligrams once a week. However, due to a misunderstanding of the instructions, her mother administered 25 milligrams, double the recommended dose. Even though the pharmacy had provided verbal instructions through an interpreter, this error happened because the instructions were not retained or clear enough for her mother to follow at home. The next time we saw the patient, we decided to put medication in dosset boxes. The patient were from quite a while away, so we requested all 4 weeks in one go. That was approved, and the interpreter was arranged again. And you would think that the compartmentalized doses of the dosset box would mean that the problem was solved, right? I was shocked to see the patient readmitted in hospital only 1 week later. I was pulling my hair out thinking, what on earth is going on? What more can we do? And I'm sure we can all appreciate in the hospital, we get the datixes, that we do the investigations, there's a tick, slightly, in my opinion, sorry to say like this, but a tick box exercise, etc., where we do all the mitigations, etc. But in this case, nothing was working. This highlights the limitation of relying solely on interpreters or verbal communication, and there is a massive gap in our healthcare system that needs to address the issue of accessibility and diversity. Once patients leave the healthcare setting, they're on their own, and this is where translated medication labels can make a life-saving difference. So what's the solution? In my opinion, bilingual medication labels. These labels provide instructions in both English and the patient's preferred language, ensuring clarity. Imagine a patient who doesn't speak English trying to interpret complicated dosing instructions in a foreign language. Now compare that to the same patient receiving medication languages in a language that clearly outlines when and how to take the medication. How much better do you think the outcome and experience would be for that patient? By the way, feel free, the QR codes in this presentation do work, so feel free to get your phone out and scan them at different times. But just a quick virtual show of hands or in our heads. How many people have come across a patient who cannot or did not speak English as a first language? I know I have. In essence, so here's the fun part. Keep your hands up if you've ever used machine learning or Google Translate or ChatGPT, for example, to communicate with these patients. Now I'd like you to keep your hand up if you're aware that the regulatory bodies such as GMC, CQC, or GPHC all do not recognize online tools or machine learning unless they have internal approval. NHS guidelines explicitly recommends avoiding online tools. I'm sure you can see the majority of the audience here is putting their hand up. So NHS guidelines explicitly recommends avoiding online tools. And if healthcare professionals use these, it can lead practitioners vulnerable to criticism, regulatory action, or litigation in the event of adverse outcomes. Written medicine is one software we've used at BWC to good effect to reduce health inequalities, improve patient experience, and reduce the financial burden on our trust. Most importantly, it improves the health outcomes for our most vulnerable patients. We have a bespoke service tailored to our patient needs that allows us to tackle these challenges effectively and in an all-encompassing solution. In my research, there was other software available, such as RxInfo, that I've shared a little snippet down here, but we found these to be less effective in finding a solution as they only had set translation options. But this isn't only a patient safety measure, it's also a way of improving the quality of care we provide. By eliminating the communication gap, we reduce the chances of errors and improve health outcomes for a significant proportion of our population. Bilingual labels don't just benefit patients, they also reduce the strain on our healthcare providers by cutting down on unnecessary readmissions and follow-up consultations due to misunderstanding. Again, I'd like to highlight, we're often described as gatekeepers in NHS. We should have a role in safeguarding it. These labels do more than translate words. They empower patients to manage their health safely and effectively. Some of the labels even include QR codes, like I said, and they can be scanned for further instructions. And we're collaborating with Written Medicine currently to develop QR-linked video tutorials in their native language. This makes the entire experience more accessible and user-friendly, not to mention helps with the NHS diversity and inclusivity agenda and the green agenda in terms of saving copious amounts of paper every year. So in addition to the bilingual labels, another effective tool we can use is pictograms. Written Medicine has identified a solution where the situation where patients may be able to speak another language, but what happens if they can't read it? This is particularly useful in PEDS where I work, where you have children coming in as first or second generation immigrants who translate for their parents. But respectfully, are we really leaving our own registration and the health and safety of our patients in the hands of people we don't know whether or not they're going to be translated correctly? Pictograms are simple illustrations that can show patients how to take their medication. It's especially useful for patients who may not be able to read. They can indicate the correct dosage, time of day, method of administration, and whether or not a medication should be taken orally or as injections. Especially in pharmacy, I think we get too hung up on the writing on the actual label, and I think that we can really utilize the modern tech to develop this in such a better way. So pictograms showed that they're particularly useful, especially around older patients or those with low literacy skills. The data speaks volumes. Understanding of instructions jumped from 38% to 89%. Adherence from 38% to 82%, and patient claimed more independence, and they rose from 23% to 75%. It's no longer theoretical, it's transformational. This kind of improvement has a direct impact on patient safety and again, reducing the admissions and improving the long-term health outcomes. But question for the audience, would you not argue that the information provided adjacent here on the MAR chart provides a useful solution to the problem? Not only are you checking the adherence based on the MAR chart, but you can scan the QR code to get more information. You can see clearly where to administer and how to dispose of the patch. I know I wouldn't be able to do that translating that to Somalian, like I said before. It was hard enough to remember how to say hello. Now, at the end of the day, patients remember what they take home. That's the label. That's the true point of care. Study shows that patients forget 40 to 80% of what we say at the counter. What stays with them is the label. We need to remember the label must carry the same weight as that consultation. So let's talk about the financial impact it has on local NHS establishments. Medication errors and non-adherence due to language barriers are costly. Hospital readmissions, unplanned admissions, and increased treatment costs make up a significant proportion of these expenses. By implementing bilingual labels, we not only improve patient safety, but we also reduce healthcare costs by preventing avoidable hospital visits. The financial cost of language barriers on the NHS is significant. In 2020, the NHS spent 66 million on translating and interpreting alone. Poor communication, according to Andrew McDonald, who's a former civil servant, cost the NHS 1 billion per year in England alone. And patients with communication barriers are 3 times more likely to experience a preventable adverse effect. This can lead to longer hospital stays, poorer patient outcomes, and additional healthcare spending. Medication errors cost the NHS millions, and many are preventable. This isn't just a safety issue, it's a financial one too, and translated labels are low cost, high impact prevention. The patient feedback we received was clear. We did a little focus group with some of the patients in our trust, and we've implemented this we've implemented this software for almost a year now. But 80% of our patients want translated labels provided regularly. In fact, 66% say that the availability of translated labels would influence their choice of pharmacy. I know patients don't have so much choice in the NHS trust, but at the same time, you know, if you think of the NHS 10-year plan where we're trying to bridge from secondary care into primary care, think about what the impact that we could have on our local GPs and local community pharmacies too. This isn't just about compliance. It's about building trust and improving the patient experience. Patients feel so much more independent and confident when they can understand their medication. In the past year, we ourselves have seen tangible end results. Fewer readmissions due to misunderstanding, increased patient independence, and even our staff are reporting fewer follow-up queries. The more confident our parents, carers, and patients are, the more they are involved and feel empowered to lead with the treatment. Even our dispensary staff are reporting fewer phone calls. But what have we learned in all this? Co-production with communities builds that trust. We have taken on board the feedback of our service users and developed in collaboration with Written Medicine to create a bespoke service at BWC. But the visuals and the language provide that true understanding. One of the, I gave a stat earlier that said 40 to 80% of the verbal communication is forgotten, but in the same paper, it said that if you have a pictogram or kind of a visual representation, then understanding increased to 80%. Standardizing this across our trust and collaborating with other trusts to make this standardized practice is the ultimate goal, if I'm honest. But let's experience it like a patient. You can scan a QR code of your choice. I'll move this out of the way, sorry. Now, I totally appreciate that translated into English, but even then we can now, you know, reduce the health inequality of people that may not be able to speak English as well. Or one of the beauties of this is if your EPMR system ever goes down, you could still have a backup bespoke server to produce the medication. But imagine being the patient. Would this make you feel safer? Would this help your mum, your nan, your neighbor? Then you already are starting to understand the value. But watch how simple and accessible this could be. And again, like I said, feel free to scan the QR code at any time. But to give you an example of a translated label as well, I've done one in Urdu below. So I'm sure you can see the impact that this can have on the information we're taking forward. If anyone's an Urdu speaker, by the way, can you just give me an independent corroboration to show that that was actually a true translation? Thank you, guys. So let me share a powerful example of how bilingual labels can make a real difference in a patient life. I know we've talked about hospital admissions a lot, but we don't know our unknown unknowns and the impact of our decisions beyond our four walls of the hospital. So a mother who didn't speak English was responsible for administering medication to a child. She was always afraid of leaving her children and relatives because they were worried that they wouldn't be able to understand how to give the medication correctly. When she started receiving these bilingual labels, everything changed. She now felt confident enough to leave the child in the care of her relatives, knowing that they could safely follow instructions. This isn't just about improving adherence, like I said, it's about empowering families to take control of their health and feel secure in their ability to take care of their loved ones. In this case, the mother actually came to the pharmacy in tears, bless her, and thanked us for being able to provide the solution because she was now able to take a night shift and leave her child with a grandma because she was confident that the medication could be administered. It goes to show the consequence of our actions reach far beyond the walls of our practice. And this is something that I really want to hit home. So this isn't just a gimmick of me trying to tick a box. I genuinely feel like it matters. And I believe the quote from the former CEO of NHS England goes some way to explain the opinions towards some of the software available to us and how we can use that in our daily practice to improve the quality of our life for all our patients. Thank you all for your attention. I'd love to hear your thoughts and I will be around for the panel discussion. But how do you see bilingual labels benefiting in practice and what are the challenges that you might face when implementing them? Some of the challenges we had was around the funding, and Claire's done ahead of me and already given some of that. But one of the ways we got around that was doing a freedom of information request for our trust. We identified the top 10 languages and then engaging an audit that identified the causes of hospital errors and readmissions within our trust and created a business case. This was then funded by our charity to solve the problem we were currently facing. But I'm open to discuss some of the barriers. My email address is there as well, and I'm happy to share any resources. Thank you very much.
Brilliant. Thanks so much, Hash. I think the last comment in the question and answer says it all. They say that this app is making me so happy. What a wonderful piece of tech. So yeah, thank you for coming along and talking about us. And now we'll start the discussion forum. And like I say, any resources that you'd like us to share with the community of practice, and we can add those to our NHS Futures page. So that would be brilliant. Thanks. So I'll ask all the presenters who've presented so far if they don't mind switching their cameras on if they're able to, and we'll start the discussion panel. I'll just start. So everybody's welcome to pop their hand up if they've got a question to ask. I'll just start with one that's come in the question and answer function. So we've got a one for you, Hash, around how did you manage to get the data for medication errors? Was it easy?
So that's a good question. In a word, no. I can see Claire as well. I'm sure she shares my pain. No, not at all. We had to be quite dynamic in the way we did it. So like I said, the first thing we did was we did a freedom of information request to identify our top 10 languages to see the kind of demographic of patients that we could get in scope. And then we went to A&E as a first, because you've got to get your heralded patients and your unheralded patients, right? So the kind of, like Claire was referring to earlier, the people that you're expected to. So in the outpatients, obviously you have, your planned appointments, etc., and then you have the unheralded patients, such as the people coming from through A&E, etc. So the first thing we did was do a freedom of information request to see the top 10 languages I used. That encompassed about 91% of our patients, and then we went from there to A&E to see how many patients are attending that weren't, native English speakers, and then we went to the outpatient team as well as the patient experience team, and then we got in touch with the interpreters. I just want to say as well, very clearly, this app is not designed to replace interpreting or anything. It's supplementary. The aim of it is kind of you have the stuff in-house, and then the bulk of at the end of the day, the language would be taken, the translated language, sorry, would be taken home with them, so that's information to take home with them. So we collated all the data, we did a mini business case, and then took it to the patient experience and innovation team and the comms team to say that, this is the plan, etc. And if any of the other departments wanted to get involved, I took it upon myself to kind of go around a lot of the specialities and do, like, when you have NMP events or kind of learning events, etc., just to say that this is what we were trying to do, collate all the data together. And then by the end of it, once the business case is created, we found that the top 10 languages encompass 93% of our patients. We then found out the outliers and scoped this, so we increased it to, I think we have 17 languages now, which goes up to 97%. But yeah, in a nutshell, no, it was not very easy. As I'm sure my colleagues are aware on here, the NHS is quite siloed sometimes in terms of the different teams, different specialities, and kind of, although we share the same patients, getting the information at each step of the chain is very difficult. So we kind of reached out to all of them, then put it together, and then took it back to the board.
Brilliant. Thanks very much. And Claire, there's a question that for yourself from Susanna Wood. How did the clinical assurance process work for Care to Translate stock freezers?
We had enough information from Care to Translate themselves that they had used bona fide native speakers of those languages, that we weren't asked to do any clinical assurance with it in-house.
Brilliant. That's great. That's helpful. Thank you, Claire. And a question for yourself, Ranjit and Sofian. There was a question in the chat just around, is there plans to look at the NHS app and the accessibility of that in terms of health literacy levels?
Yeah, so yeah, we have been working with the NHS app team. They lead on digital inclusion, and so we've been talking to them about two things. One, about just all the information on the app, and with the health literacy lens. So Joe Stedman, who leads on the digital inclusion portfolio for the app, has been looking into that. I think the challenges on translation, they have been identified. I think the challenges are how can we work that up, and which parts of translation can we look at, and that's been discussed at the same time. So we are working with the team, I think, and I think there's some other work that we're picking up. So when we launched the community languages, the interpreting and translation framework in May, there was a particular work around AI and the use of AI interpretation. So we're taking, and some of the national recommendations. So they are part and parcel of some of those discussions that we're having at the moment.
Brilliant. Thanks so much, Ranjit. Yeah, brilliant. Thank you. That's really helpful. And coming back to yourself, Hash, there's a question for you. Is this being used on discharge summaries and outpatient letters as well as on the labels?
So that's something that we're currently developing now, if I wanted to do so. The aim of the QR code was, in essence, I don't know if anyone scanned it, but if anyone scanned the Symbicort one, it takes you to the Symbicort pill. And then the aim is to then translate them into the various languages. So it's currently in development, but at the moment it's mainly used on the medication labels in and of itself. One of the challenges we had was making sure that the patient had some kind of translated medication information to take home with them. So we started with that, and now we're looking at the kind of wider scope around pills and administration, etc. Another cool little gimmick is with the QR code, you can actually get culturally sensitive animations. So, for example, an inhaler, and then you could have the counselling alongside the video, so that the patient can then see that as well.
Brilliant, thank you. And then back to Claire, we've just had a question come in from Sharon. Did you experience any resistance from colleagues who manage interpreting services? Any suggestions for getting organisational buy-in to make this kind of medical translation up higher on the organisational agenda?
I didn't have any trouble at all with anybody who managed interpreting services. They were very happy that I wasn't trying to replace them. I was just trying to give a little, alongside thing that would help. And in terms of organisational buy-in, that was very simple. I went straight to Datex and downloaded the number of times that we'd had a complaint, or either a complaint from somebody who couldn't understand, or where a healthcare worker had reported that they hadn't been able to get hold of an interpreter in a timely manner to have the conversation. And I had enough in one quarter. I think I had 5 Datexes just on that. So that was enough proof for them that could be improving the situation.
Brilliant, thank you. And just there's a question just come in as well for you, Claire, just around, are healthcare professionals able to create playlists and add their own questions? So for example, in spinal cord where they work, they have a playlist about explaining what these are, what would be useful as interpreters?
Yeah, so we were only doing maternity and neonatal. So we had it all on one playlist, but you can have an organisational I can't think what the word is, contract, where you have individual sets of playlists for the individual areas, or you can indeed just, like we did originally, we still haven't rolled it out to the rest of the trust. We still just have Mat Neo. So yeah, you can, and yeah, then you absolutely build your own playlists. You can also do what I did a little bit, and then it didn't work particularly well, so I stopped. Which is give service leads in your department their own, give them admin and let them do it. So for example, I set up a load of maternity ones, but then I gave the infant feeding lead admin rights to go in and create her own playlist. But actually she made a bit of a muddle of it and didn't quite understand what she was supposed to be doing. So generally I've set them up for them. But yeah, you can give anybody admin rights to build whatever playlists they want to build.
Brilliant. Oh, that's really good. Thank you, Claire. And Hash, just there was a question earlier for you as well. Just someone asking if you know if the label translation tools also work with simplifying language with respect to health literacy.
Yes, yeah, so like I said, that's something that it was identified in our unknown unknowns when we launched this. So one of the aims is to reduce some of them. So we have set. Working peds is very difficult because you don't get the usual amlodipine once a day dosage. You know, it's going to be crush and disperse a tablet, or you're getting liquid, etc., and very different. So one of the challenges we have is where we're trying to simplify some of the codes, yes, but in pediatrics in and of itself, the dosages are that much more complicated. So again, one of the things we were looking to do was kind of have that audio input alongside that. But that is one of the challenges and one of the things that's come up out of this. And again, if anyone wants to get in touch and see how we do, kind of 3 months, 6 months down the line, happy to share some resources.
Brilliant. No, that'd be great. Thank you. Anything that we've got already can be shared. And then, but yeah, definitely we'll keep in touch to get to sort of see how it's going down the line as well. That would be really helpful. Thank you, Hash. There was a one for yourself, Ranjit. A question: are there plans for work to continue into 26, 27?
Around health literacy?
Yes.
Yeah. Yeah. So we are still we're still working on it at the moment. So now that we've had the budget, what we are doing is doing an exercise on a zero-based budget similar to what we had this year, and then we have to put our submissions in. So that's open for negotiation at the moment. So I'll keep you updated through this community of practice, what we're looking at. Is that okay?
Yeah, thank you. That's really helpful. And someone has just asked another question for yourself, Ranjit, and in terms of, can you please share some of the activities programme around the achievement of priority 2, digital equality?
Yeah, so when we had the core 20 and the 5 strategic priorities, priority 2 was digital inclusion. So there was so we worked with the ICBs on making, so there was a couple of things. So one, we launched the digital inclusion framework, and we made sure that that was put into the planning guidance for last year, and then ICBs were delivering to the digital inclusion framework. Now what we've done is did a pause and pivot and moved a lot of that activity into the digital equitable drive around digital. So it's one about working with the NHS app team to make sure that everything they do is inclusive of those that are face challenges around digital poverty, access to digital means, making sure that the digital space doesn't leave the very core 20 population that we're working with, doesn't leave them behind, and just goes to those that are digital literate So digital poverty and access to digital means is absolutely key. But then the other side of it is looking at the app itself, about how user friendly it is, how engaging it is, and inclusive it is. We are also doing some pilot work. We're just waiting for our business cases to be approved, but funding ICBs to do some more work around the digital space. Sophie, is there anything else? Because I know you're involved in some of that work. Is that the main work that they've got
Yeah.
underhand? Yeah.
Yeah, that's right. Probably just the one to add is there was recently published an ethnicity recording improvement plan.
That's it. Yeah.
And what we're looking to do is I can share that in the link in the chat, by the way, which would be good. What we're looking to do is sort of the implementation of that recording plan. So that's another sort of piece of activity. And then alongside that, we're still sort of trying to scope out what other bits of activity would look like. So, for example, I think there was something mentioned around clinical assurance from one of the colleagues for Claire. So it's looking at potentially the sort of risk, quality, and safety of AI and translation. So potentially, what would a policy paper look like? And that's probably not as far as some of the other stuff, but that's a consideration as well.
Yeah.
So it's and I think I did put it in the chat as well, but I think the main thing in sort of the digital work stream is how can we work cross sectors or cross teams in NHS England, and we've got a wide variety of teams, some that I didn't know existed, and then you've got some who are experts in AI, you've got us from me and Ranjit and others who are experts in health inequalities, and it's kind of bringing that all together because it's such a big, like AI, it's really easy to sort of say the words, right, two sort of letters, but in itself and in terms of landing it in healthcare is quite a big job. So I think cross collaborative working will be really, really important for that. And then that's what we're looking to influence as a team.
Yeah. I just wanted to add something to that. I think we're really keen, like the health literacy and the community languages, is making sure that when we're talking about the digital space, that it's not seen as an alternative to. Because in all the research we did around the community languages framework, patients said that their preference was face-to-face interpretation. So we've got to make sure that that choice is still what patients want. But as an alternative, if AI tools are looked at, do they have the safeguards in place? Do we have a national do once policy that would say, look, here's managing the risk and managing the safeguards? And we know some of the risks. I know, Claire, you mentioned the Google Translate safeguards, but we know that's an issue that myself and Sophie are also working with the Crown Commercial Service on just some of the market analysis that came out from our framework, cost versus quality often. If providers are only given a finite figure, and I suppose, Hash, this comes back to your issue about funding. If NHS providers are being commissioned by their ICBs with a finite figure of this is all we're going to have for your interpreting and translation or your health literacy or your access portfolio, they're going to then have to choose the best approach on who they actually commission. And that's that challenge around quality of interpreters, what agency they go to, how much they actually can charge, and how much service delivery they can. And that we just need to get into that space to understand what's going on. So that's part of what we're doing at the moment. Is that okay?
Brilliant. Yeah, no, thank you. Really helpful again. And I think we could keep going all afternoon, but I'm conscious of time. So I'm going to finish the discussion panel there. If anyone has put a question that hasn't been answered, we'll get questions and answers circulated afterwards. But thank you for all the questions and comments, and thank you again to all of our presenters so far for your presentations and for your participating in the discussion panel. That's been really helpful. So I'd like to move on to our next presentation, our next session, which is with Lorna Dawson around jargon. So I'll just hand over to Lorna. Thank you.
Thanks, Emma. I'm just going to share my screen. I've got a few screens going on for this. So I'm hoping they'll work. There we go. So hopefully, can anybody, Claire, I can see you. Can you see it if it says what's your jargon on the screen? Okay, thank you. Right, yeah, and thanks for people who put their hands up, that's fab. So hi, my name's Lorna Dawson. Oops, sorry, I was just switching between screens then. I am the health literacy specialist in the North East and North Cumbria regional health literacy team. I'm going to do a bit of an interactive kind of part of the community of practice today, because feedback that we've had is it would be really nice to do more interactive elements. So Hashim, I think your introduction will have gone down really well. And then at the end of it, I'm going to do kind of get you to do take part in a form survey as well, that will hopefully help us. But let's go through, sorry, multiple screens, right. So what's your jargon? A lot of what we do in the team up north is kind of changing jargon and encouraging people to use simpler words. But jargon in itself are kind of special words or phrases used by a certain profession that it's easy for them to understand, but it's difficult for people who aren't in that profession or group to understand it. I've got a few examples here. So my sister is a pharmacist, and she's constantly going on about TTOs. And I'm like, I don't really know what those are. I think it's medicine that you take home. So it's like to take out. Other ones that I found are a self-advocacy group. So a group that kind of is kind of championing itself, and even championing is possibly jargon. Procurement process. So I thought that was kind of, we hear that a lot in the NHS. It's kind of like a financy term. But I'd say that's kind of how do you buy something in your organization? Policy. So recently, we've done some community engagement in kind of like a local college, and we gave them students a policy or part of a policy, and they actually said kind of, I don't actually know what a policy means, or like what a policy is. My background originally is in libraries, and we do a lot of interlibrary loans. And that's basically where you're borrowing something from another library for you use it here. So we're getting something from another library for you. And even in health literacy, we have our own jargon. So kind of readability is probably one of our key things. I mean, health literacy is probably our jargon too. But things like how easy are something to read. So these are some examples of jargon. But why is it a problem that people don't understand it? These are some of the things that people have said when we've kind of taken out health information into the community that contains jargon. So they've said it's daunting. It would scare me. So those big words on the page that they don't understand, like something's going to happen to me, but I don't actually know what's going to go on. It sends you into a panic. And that big block of text in the middle, that would stop me from coming back. So if they've got a wall of words that they don't understand, it could actually have an impact on whether people turn up to appointments in the first place. And this is not how we want people to be feeling. It's something that we have control over. But I guess sometimes it can be hard to spot your own jargon. So we're going to do a little bit of jargon spotting today, first of all, in a piece of text that I've found. So what I'd like you to do is just have a read of this paragraph here. So it's got some quite long sentences, some jargon in there. And what I'd like you to do, so I'm not giving you any clues at the moment about how to spot jargon. So you're going to have a go yourselves to start with. What I'd like you to do is kind of have a read, pick out words that you think might be jargon, might be difficult to understand, could be a phrase as well. And then I'd like you to scan the QR code and type your jargon into the form that comes up or the Slido. If you don't have your phone to hand, you can go to slido.com and type in 636 8755. So I'm going to kind of leave that on the screen for you to have a read and kind of have a think about what's the jargon. I'm going to check up on this Slido to see how people are going so far. So I'm sorry if my screen kind of skips a little bit.
Lorna, we've got a comment saying the poll's not active. Is it
not?
working?
Oh,
is it working
sorry.
for people or not?
I've just pressed a button. Is it working now? Thank you, Kia. Okay, fab, and things are coming through. This is great. So things that are coming through are stuff like, let's say, Vigon pumps. We've got real world evaluations. What does that mean? I'll be honest. So I had to rewrite this. I had to Google that one. Things like an innovation grant. Evidence generation. Things like so I like this one. So within a community setting. And I know that's something that people say a lot. I'm going to switch so you can see the results now too, actually. So hopefully it should appear. There they are, a little bit small. But within a community setting, so I'm in an acute hospital and people say that a lot, kind of community setting, but I don't think people like patients necessarily know what the difference is between, say, community and hospital. It's easier just to say where the venue is. Things like staff experience, I would agree. So it's not necessarily that we don't understand the words, but kind of what does staff experience mean? It might be something slightly more complicated than it needs to be. We've also got finalizing for next steps. Yeah, kind of that seems like corporate jargon, I would say. So, and even like, so a lot of people seem to have said the 24-25, and I agree with that completely. So the way that date is presented, fab. So thank you very much for spotting those. I've got another question for you now. So hopefully that's warmed you up, but this one is a little bit harder. So you've spotted loads of jargon in there, but how could you tell what was jargon? So when you looked at kind of that word, say innovation or 24-25 or kind of neurosim or community setting, what kind of thought process went on in your head to say that's jargon? And sorry, and again, if you could kind of, oh, I'll need to put the second poll on. Bear with me a minute.
No, I've done it, Lorna.
Oh, thank you. If you could kind of type in answers, that would be great. And I think I've got them running. So I've got words I wouldn't understand. Remembering how you felt about 10 years ago. Wouldn't use if I was speaking to my friend in a pub. Things that actually didn't make sense to you. Things that maybe you found it hard to follow. Taking more time. Yeah, I think if it kind of makes you stop and you're like, or have to read it twice, that's a really good that's a really good test. Kitchen table test. I don't know what that is, but I want to find out. If you can type that in the question and answer, that would be amazing. Yeah, words that give me pause, longer or complex. Yeah, kind of language that people in corporate settings think. I don't know if I can scroll down these. Yeah, I can. Yeah, not understood by people outside of the group. Yeah, I love to use the question kind of what does it mean? What does that mean? Or actually sometimes it meant nothing, or it could be something that you'd find hard to explain to somebody else. Yeah, not everyday words. That's great. So I'm doing this activity because I think this is easier when it's, oh, that's a great test as well. Kind of, would a 9-year-old understand? Would an ESOL person understand? Kind of, could I explain it to my kids? Yeah, and that it could mean different things. Fab, that's great. So I would say it's easier to spot jargon in somebody else's writing than your own. But that's why I'm getting you to think about the ways that you would spot it. So hold on to all of those tips for spotting jargon, because I'm going to ask you soon to actually spot it in your own writing, which I think is one of the hardest things. Yeah, and here I've just got 3 tips for you, but I think all of the tips that you gave were great. So for me, I look for long words. So things like evaluations, like generation, finalizing, stuff that is longer than they need to be. Kind of, we had kind of, if somebody said like I wouldn't know it if I didn't do this job, or it sounds like it's from another profession. Yeah, so I kind of think, well, if I didn't work in the NHS, or if I didn't kind of, yeah, work where I do, would I know what that means? And that's quite helpful for things that possibly are familiar to you. So that impacting on patient staff experience is probably something that we hear a lot. So we tend to know what it means. It's like, oh, it's to do with staff and how they feel or something like that. So we automatically translate it quite quickly. But it's kind of thinking, actually, if I didn't work in the NHS, would I actually know what that means? Similarly for community setting, I know that that's kind of not the hospital. But if I didn't work here, would I know what that meant? And also a lot of people said kind of, if I explained it to somebody else, or just imagine that you're someone else. So you could, we use a character called Betty. So I imagine that I'm Betty, or just kind of like somebody on the street, the kind of like the bartender. Yeah, would they understand what kind of 24/25 meant? They might think it's the 24th or 25th of September or something like that. And they definitely have no chance of understanding what an Eurosim was, or Vigon pumps. Fab. Another way of spotting kind of jargon is using something like an editing tool or a readability tool. So I'm involved in the update to the NHS readability tool, which the regional team and South Tyneside and Sunderland are working on alongside Newcastle University, so Jill Rowlands. So the tool already has a feature for kind of saying, oh, this word might be jargon, or it might be a bit complicated. So if you copy and paste your kind of text into the readability tool, it'll highlight certain words or sentences in certain colours. And if your word is highlighted in green, that means it's a complex word. And we've actually kind of put those, we've got a thesaurus behind it. So we've got a list of medical words that we know are quite complicated to understand. So we've asked it to highlight those specific words in green, and also kind of suggest simpler ways of saying them. It also highlights words that are long. So these might not necessarily be kind of specific jargon or very medical words, but they will still kind of cause people trouble because they're just long, because shorter words are easier to read, and those appear in purple. But what we'd like to do is add to that list of kind of complex words that we know would be difficult for people to understand, and add our specific jargon into it. And because kind of we know our jargon, but we also know we're the best people to say kind of what that jargon actually means. We'd like to know kind of, yeah, what's your jargon, and actually what's a simpler way of saying it. And that's what I'm going to ask you to do now. So what I'd like you to do is, if you could, find just a piece of text that contains some of your jargon. So it could be an email that you've sent somebody, could be something on your website, so about your team, could be a letter inviting people, or a poster, a document that you recently wrote. And what I'd like you to do is, and I'm saying do this now, so we do have time, we've allocated time for it. What I'd like you to do is spot your jargon. So kind of do that test, kind of, would this make sense to, how would I explain this to a friend in a pub? Would I use that word? Kind of, does that look kind of like more medical? Would I have to Google that? Kind of, could I explain that word to a child, or would I need to explain that word to a child? Look for kind of long words, or you can pop it into the NHS readability tool and see if any of those words come up highlighted. They're probably likely to come up highlighted in purple rather than green. And once you've done that, what I'd like you to do is send us your jargon, and we're going to add your jargon into the NHS readability tool so that it can help other people. To add your jargon, what we'd like you to do is scan this QR code. We ask you a few questions like whereabouts in the UK you are, but the bulk of it is kind of saying, can you write your jargon? And also kind of suggest a simpler way of saying it. So what I'll do now is I'll put some links into the chat, bear with me. What time are we on? 22. Emma, let me know when you want me to kind of finish.
No problem. Yeah, we've probably got a few minutes if that's okay, and then before we
Yeah,
have to
yeah.
round up. Thanks, Lorna.
No worries. So I'm just going to pop this in the chat now. It'll be there. Oh no, it'll be the question and answer. You can also just type NHS readability tool into Google and it'll usually turn up. So I've just popped the link to the NHS readability tool in the chat, and now I'm just going to get a link to the forms in case people can't scan the QR code. Where are we going? There we go. Nicola, you've asked, is the current jargon list available anywhere? I'll see if I can get hold of it for you because it is a list. Not copying and pasting. Won't let me copy and paste that. Oops. So if you could just scan the QR code and I'll find the link after. That would be fab. And thanks, Angela, for explaining. So the if other people haven't heard, I hadn't. Kitchen table test is language you would use around the table with friends and family. That's great, yeah. Thank you, Kia. So Kia's just posted the link to the forms if you can't kind of scan the QR code. But this kind of poll will be live after this session as well. So feel free to kind of go away, and as you're kind of going about your day-to-day work, you might be like, oh, actually, like that's my jargon. So send that to us, tell us kind of what's your jargon, and also kind of what would you say instead of it. Dawn, you've got a question. How do you get the examples of what to use instead? So with this original list, the alternatives were already there. For what we're doing now, the alternatives are coming from you guys. So I guess it's kind of your field testing with the people that you support around what seems to work, what seems to make sense for people. There are some really useful websites like the NHS A to Z, which kind of gives pointers on, particularly for the NHS, simpler words to say that the NHS recommends you swapping. Sometimes a good way of thinking about what is simpler is just kind of the shorter words that you can use. What's a more everyday way of saying it? There's not necessarily a hard and fast kind of answer. And I agree with your point about numbers. Poor health numeracy is definitely a big issue. I don't think the tool picks up on kind of if you've used numbers and whether they're simple to use, but hold that thought because Emma is going to ask you, tell you a little bit more about the different ways that we're developing the tool. Shall I move the slides on, Emma?
Yeah, brilliant. Thanks, Lorna, if you don't mind.
Yeah.
Yeah, thank you so much. So yeah, thanks for that session, Lorna. So hopefully that's helped everybody start to have a think about what your jargon is and how you can spot it. The QR code that Lorna shared in her presentation is a form to help you tell us, like Lorna said, what your jargon is and suggest simple alternatives. And as Sofian said at the start of the community of practice, we're also making more improvements to the, so the jargon's one part of it, but then we're making other improvements to the readability tool. So this survey is asking you for feedback around the tool itself, so not just the jargon, but just how do you use it, how helpful is it, what could we improve and things like that. So that's a QR code. Kia's shared the link in the question and answer and the deadline, and we'll share it with the resources when we send the email out after the community of practice. But the deadline for responses is the 31st of January. So it would be great to hear from as many of you as possible on both the jargon form and the main readability tools survey feedback form as well. Next slide. So the next community of practice is on the 9th of February. All community of practice is all going to be managed via Eventbrite now. So this is just a link to the Eventbrite so you can book your place. So it's the same community of practice. Same people who are involved in it. We're just managing all of it through Eventbrite now. So you might have accessed it in different routes in the past, but this is the link to let you sign up for our next community of practice, which is the 9th of February, and we'll send out a lot more information near the time as well. Next slide, please. So just to help round off the session, again, thanks to everybody for joining and for the presentations as well. We'd just like some feedback from yourselves. So if you wouldn't mind, there's going to be a poll on the screen. So on a scale of from 5 to 1, so 5 being very good, 1 being very bad, how would you rate the overall meeting experience? The poll should be on the screen there for you to respond to. hopefully you've all had a chance to respond to that poll. The questions also in the chat as well. And next one is, what went well and what did you find beneficial? Again, if you could answer on the poll or in the question and answer function, that would be really helpful. So this one's just as a word cloud. If you could just add some comments in, that would be, would really appreciate that. Thanks. Are the polls working okay for everybody? Brilliant. And the next question is, what could we improve? Again, as a word cloud, if you'd just like to put any of your thoughts on here, just so we know what we can improve on for our future community of practice meetings. Brilliant. And next slide, please. Yeah, so just a few final comments. So thanks again for attending today's event. Hopefully you found it really helpful. All the recording and the presentations and any other support information will be shared as soon as possible after the community of practice, and it will be made available on NHS Future platform as well. The dates so far for 2026 are the 9th of February and the 11th of May. And again, if you don't wish to attend these meetings or receive updates, please obviously let Yo-Yo know, and she'll remove you from the distribution lists. But yeah, thank you again for joining, and I hope everyone has a lovely Christmas and New Year, and we'll see you all on the 9th of February. But thanks again.